السلام عليكم ورحمة الله وبركاته. مساء الخير لكم جميعا. Good evening, everybody, and welcome to our first webinar for this year. We are planned to do at least one webinar every quarter. This is under the umbrella of the National Health Center. First of all, I would like to ask to thank my colleague, Dr. Fahad Al-Mahmadi, for organizing all of this. And I will ask my chair and co-chair, Dr. Najmuddin Al-Shahidi, Dr. Naeem, and we will get started in few minutes. We have a change in schedule. Dr. Al-Shahri for family issue, he will not be joining today. So our first speaker will be Dr. Najmuddin Al-Shahidi, and he will cover the topic for resynchronization therapy and sudden death. As you know, our webinar today is about the role of the arrhythmia specialist in tackling the heart failure epidemics. Heart failure is one of the most common cardiac problems nowadays, and the magnitude and prevalence of such disease is increasing. Fortunately, with advancement of the preventive program, the catheterization technology, the medication, the incidence of coronary disease over the world is probably on the decline, not in all parts of the world. Many other conditions are actually, their prevalence is improving. However, few conditions are actually on the rise. Example of these condition is the heart failure, because it's the end pathway for many of the cardiac problems. So from the perspective of electrophysiologists, we will look to different aspects, different issues which might happen in patients with heart failure, specifically atrial fibrillation, ventricular arrhythmia. How can we help with device therapy, whether it is an ICD for prevention of sudden cardiac death or cardiac resynchronization therapy for potential improvement in the patient symptomatology and the patient ejection fraction and probably survival. Our first speaker today will, as I mentioned, will be Dr. Najmuddin Al-Shahidi. He's a pronounced electrophysiologist from King Faisal Specialist Hospital, a lot of experience in device therapy, arrhythmia management, atrial fibrillation ablation, VT ablation. He will be talking about the resynchronized therapy, device option, and when to consider. As I mentioned earlier, he also will touch on the primary prevention ICD and secondary prevention ICD indication, specifically in patient with heart failure. So, Dr. Najmuddin, the mic is yours. You can start, please.
So thank you so much, Dr. Yahya, for your nice introduction. And it's really my pleasure to be here in this meeting. Thanks for Dr. Fahd for inviting me to be part of this meeting. So I was asked to talk about cardiac resynchronization therapy. And I just heard that Dr. Sherry will not be with us, so I will, without any slides, I will try to say a few words regarding ICD indication in the setting of heart failure, particularly regarding the primary prevention, and one word regarding the secondary prevention. So let's go through the history of resynchronization. I would like just to remind everybody here that in the field of resynchronization, everything started first with atrial resynchronization, and that was a long time ago. It was in 1989, where Jean-Claude Daubert, a French electrophysiologist, reported that some patients presenting with heart failure with preserved ejection fraction, when they are presenting with such intra-atrial or anteratrial delay, as you see here, with prolonged PR interval, and you see here by studying how the LA activation is delayed here in this example, 140 milliseconds. So when we resynchronize this patient by pacing simultaneously the right atrium and the left atrium through the coronary sinus, they are significantly improving, and the potential pacemaker syndrome they were presenting with will disappear. And you can appreciate here how different is the atrial activation. So from this biatrial resynchronization, we went to ventricular resynchronization by biventricular pacing. And again, in patient presenting with delayed activation regarding the left ventricle, and in this example here, the LV activation was delayed by something like 190 millisecond in the sitting of this left bundle branch block. And at that time in 1994, while adding to the RV pacing, LV pacing here located in a branch of the coronary sinus in the posterior region, you see here how we are able to obtain a narrowing of the QRS in this patient presenting with left bundle branch block and wide QRS. So everything started around this this date here in 1994. So again, the concept of ventricular resynchronization by biventricular pacing, because biventricular pacing is just one way of CRT. It's not all cardiac resynchronization therapy. So it started again by Serge Gazot in France in 1994. So since that date, we have some observational studies, some animal models, until we reach the proof of the concept with this first ever randomized controlled study, which is called the MUSTIC trial. So this is the first randomized controlled trial in the field of resynchronization therapy by biventricular pacing. And you can see here that just 3 years later, we have the CARE-HF trial, trying to see, it was a morbidity mortality trial. So it was a positive trial, significantly decreasing the morbidity and mortality in patients presenting with heart failure. And few years later, CRT by biventricular pacing obtained the class 1A indication in patients presenting with advanced heart failure, class 3 or 4. And just 3 years later, even in patients presenting with mild symptoms of heart failure, they are still, when they are presenting with electrical dysynchrony in the form of left bundle branch block and wide QRS, it's class 1A indication for this technique. So since then, we had something like more than 20 randomized controlled trial in CRT, and 4 of these trials were even a morbidity mortality trials. And what they demonstrated here, all these, including those trials, included something like 10,000, more than 10,000 patients. All these trials showed a significant improvement in symptoms, significant improvement in quality of life, a significant improvement in exercise capacity, reverse remodeling of the left ventricle by decreasing the size and improving its function, particularly the ejection fraction, decreasing of the hospitalization rate, mainly by decreasing the heart failure hospitalization and decreasing the mortality. So this is an illustration of what we will be talking about. You have here a 64-year-old female, newly diagnosed with heart failure with reduced ejection fraction. We are talking about here about non-ischemic dilated cardiomyopathy, and the ejection fraction, as you see here, was 25%. And you can appreciate how the QRS are wide. It's something like 160 millisecond. Left bundle branch block here, small R wave, deep S wave here, positive in lead 1 and AVL, and positive as well in V6. So this is typical left bundle branch block. So since this patient was still symptomatic despite being on optimal pharmacological treatment, so we decided to implant a CRT. So that this is the result after biventricular pacing, and you see you can appreciate how we obtained a narrowing of the QRS, and it's reflected in significant improvement of the ejection fraction from 20-25 to 30-35 percent, and the heart failure class decreased from class 3 or 4 to class 2, but still she was presenting with some symptoms. And I will explain the reason why after obtaining such a narrowing, why after improving the ejection fraction she was still symptomatic. So I would say that the biventricular pacing demonstrated everything regarding the symptoms, regarding the improvement of the ejection fraction, regarding the reduction of the mortality. And on top of this, and this trial here, this study was published in 2021, so just 3 years back, where they collected data coming from 1,500 patients, either de novo biventricular pacing or upgrade from dual chamber, single chamber to biventricular pacing. And they demonstrated here that the success rate of implanting a device is really very high, 97%, the implant success, whether a de novo patient or upgrade to CRT, that it is safe and low risk since the rate of complication is really extremely low. So I can finish my talk here because everything is looking like beautiful with the biventricular pacing. However, it's not coming without some concerns, some problem. I will not discuss about the underutilization of CRT. I will be focusing mainly on the non-response of patient implanted with the CRT, mainly biventricular pacing. And you see here, before implanting a CRT, you have time to optimize the pharmacological treatment, and then because the patient is not responding very well to pharmacological treatment, you decide to implant a CRT. So you have to expect something like 60 to 70% who will be a good responder. Some of them, 15%, are even super responder. Some of them are just responder, 55%. So the majority will respond. But here we are still dealing with 30 to 35% of patients who are not good responders to CRT. And that was reported in the main landmark trials, or you recognize here the main trials in CRT. All of them, they report something like 30 to 35% of non-responder. So if I ask the question, what is the rate of non-response when we are prescribing ACE inhibitor or the most recent even pharmacological treatment? What is the non-response to beta blockers? And you will be surprised, it's as well 30%. So regarding the non-response to CRT, one might ask the question, or maybe the hypothesis, that 30% might be a constant rate of non-response, whatever the therapy is applied to our heart failure patients. I don't think so, to be honest, probably not. The second hypothesis, 30% might be the non-response rate to heart failure desynchronized patient selected according to QRS and implanted in biventricular pacing. So certainly, yes, I would answer in non-optimally selected patients. If we are not selecting appropriately the good candidate for CRT, we should not expect any improvement in patient. And we will see how to select appropriately the patient who will be a good responder to biventricular pacing. The third hypothesis, maybe the 30% could be a mix between a non-response rate in these patients here and patient presenting with non-delivered therapy. Despite implanting LV lead, despite being able to implant a LV lead, still the patient is not responding. And maybe because the lead is not implanted appropriately. So to summarize what I'm talking about, so the non-response could be related to non-appropriate selection of the patient, non-optimal position of the lead, the LV lead, or maybe because of a non-optimization of the device, and this is really important part of it. So let's go through the non-optimally selected patient. So we're talking here about left bundle branch block, and the electrophysiologists are familiar with this electroanatomic mapping. So this is the RV, this is the left ventricle. So those colors, it means here in red and yellow that this is early activation. So in the setting of left bundle branch block, the RV, the right ventricle, is activated first before the LV, and you see the most delayed part of the LV is the lateral wall. So we can imagine if we are able to implant a lead to pace this region here, which is the lateral wall, which is the latest part of the LV to be activated in the setting of left bundle branch block. So we'll be able to resynchronize appropriately the heart by biventricular pacing. Whereas in right bundle branch block, so here there is already early activation here in the lateral wall as compared to the RV, since we are talking about right bundle branch block. So it doesn't make any sense if we are implanting an LV lead here and expecting any resynchronization, because we will be pacing or activating a region which is already early activated. So some of them, when they are presenting with really very wide right bundle branch block, it might mask a left bundle branch block. And in this situation, this subgroup of patients, maybe they could be a good responder to resynchronization. So this is a narrow QRS here in patient presenting with normal conduction. So how it's reflecting in terms of contractility, and this is coming from a CT with the 3D reconstruction. And you can see here homogeneous contraction of the left ventricle. Whereas in patient presenting with a wide QRS, left bundle branch block, if we look how the LV is contracting, you don't need even to here to look at the echo parameters. You can see here just by eyeballing, all the segments are not contracting and at the same time. So there is not only interventricular dysynchrony between the RV and the LV, but even different segments of the LV are dysynchronized. And the latest activated wall is the lateral wall. So while placing appropriately the lead to anticipate the lateral wall of the LV, we might be able to synchronize appropriately the heart. So we will be talking about the duration of the QRS, and our decision is made on this, on how wide is the QRS, and not only the QRS duration, but the kind of the intraventricular conduction delay they are presenting with. And I was mentioning that we are talking about left bundle branch block. And if I'm showing you this tracing here coming from two different patients here, so they are looking similar. So both tracing, the QRS duration is 140 milliseconds. And if you compare almost lead by lead, the morphology and the axis is the same. So positive in lead one, positive in lead one, negative in V1, negative in V1, and so on. If you can compare lead by lead. However, I can tell you that this patient is presenting with true left bundle branch block, and this one not. It's not a true left bundle branch block. And the reason I'm mentioning this true left bundle branch block, because I'm seeing here a notch in lead one, a notch in AVL, and even if we look carefully at the other leads, there is a notch or a slurring of the R wave. So by definition, this is really a typical left bundle branch block. And if you look at this one here, at this tracing, the second tracing, you can appreciate how nice is looking the QRS. There is no notch, no slurring everywhere. It's really very smooth. So despite being wide, it's not a typical left bundle branch block. It's just a left bundle branch like pattern coming from patient presenting with left ventricular hypertrophy. So if we are implanting a biventricular pacer in those patients, we would expect more response in this patient who is presenting with a typical left bundle branch block. So those are the morphology, those are the criteria, sorry, the criteria to define a strict left bundle branch block coming from this publication from Strauss. It's called the Strauss criteria. So QS or RS morphology in V1 to V2. The QRS duration should be more than 140 millisecond in men and 130 millisecond, more than 130 millisecond in women. And you should have a notch or slurring in at least two different leads, lead 1, AVL, and mainly V5 and V6. And in the guidelines, more and more, we are talking about the Strauss criteria regarding the definition of left bundle branch block. So not only left bundle branch block, I was talking about the duration. So when it's about measuring it, so it's not really easy. We should not think that it's really easy to measure the QRS duration. In which lead should we measure the QRS duration? Should we consider just one beat or different beats? Should we average in all leads? Or should we take into consideration only the longest QRS? We still have to define where the QRS is starting, when it's ending. Should it be manual measure using calipers? And I believe it's really better to do so. I'm not all the time relying on the value given by the machine. There is a significant errors. What is the paper speed? Should we just look at 25? The more we are, for example, 50 millimeter instead of 20 millimeter per second, we will be able to better define where the QRS is starting and where it's finishing, and what is the reproducibility intra-observer and inter-observer. Several studies were done regarding this issue, and the discrepancy is really very high. So it's really important to measure the QRS duration because, as I will show you, the cutoff currently to implant a biventricular pacer, it depends on the QRS duration. So we are taking our decision mainly based on the QRS duration. And the reason is when it's below 150 millisecond, it means when we are dealing with the narrow QRS, 120, 130 millisecond, you see here the line of identity. So it's largely crossing the line of identity. So these patients are non-responder for sure. So the more you are implanting patient presenting with a wide QRS, and in this study, they consider the continuous variable the QRS duration. So the more the patient is really getting benefit, and the cutoff is more than 150 millisecond. And it's not by chance that in the major trial made at CRT, if you look at the patients who are getting more benefit from CRT are the patients presenting with wider QRS exceeding 150 millisecond here. Again, you have the identity line here. So patient less than 120 millisecond are largely crossing the line, and those are the patients who are really getting benefit from it when the QRS duration is exceeding 150 millisecond. It was the same in the reverse study. It's even 152 millisecond. So those patients are benefiting more than those patients. And it was the same in Raft study and so on every time. And this is the reason why currently in the guidelines, it is clearly mentioned that not only left bundle branch block, but the QRS duration matters, and it should be exceeding 150 millisecond. As I told you, when it's about left bundle branch block, adding a CRT when there is indication of ICD insertion and the patient is presenting with left bundle branch block and wide QRS, so they are getting really benefit from CRT. Whereas when it's about non-left bundle branch block, and particularly right bundle branch block, or just intraventricular conduction delay, whether you are implanting just an ICD or CRTD, it's not improving at all the heart failure hospitalization or death. So again, the message should be really clear. We are implanting patient presenting with electrical dysynchrony, uh, left bundle branch block, wide QRS, duration is exceeding 150 milliseconds. We should not neglect the multimodality imaging before implanting a CRT because they are playing really a major role, and particularly cardiac MRI. So in our center, we are not implanting anymore any device before having cardiac MRI. And the reason, not only it will comfort you in the ejection fraction, you will have more than the echo, you have cardiac MRI. And if the echo and the MRI, there is no discrepancy in the ejection fraction, it's a supplementary argument that your ejection fraction is depressed. But nowadays, really, the echocardiographer are performing really very well regarding the estimation of the ejection fraction. But mainly, the cardiac MRI will tell you if the lateral wall is viable or not. If you don't have any viability within the lateral wall, just forget. If you have here late gadolinium enhancement, like in this situation or here in this situation, just forget about resynchronization. And from time to time, when it is in the post myocardial infarction and when the septum is interested here, so the tissue here is not viable at all. So we should really ask for cardiac MRI to be sure, particularly regarding the lateral wall, that we have a viability. And in this way, because this is the region where we will be implanting our LV lead. So if it is dead, the patient will not improve anything, will not be able to obtain any resynchronization. So that was the selection of patient. It's mainly patient, again, presenting with left bundle branch block, QRS duration more than 150 milliseconds. And we are sure in prior to implantation that we have a clear viability within the lateral wall. So what about non-optimally implanted patient? What does it mean? You see, the technique today is a transvenous one. It's the coronary sinus route. It's a totally transvenous procedure. It is a simple technique. The success rate, as mentioned before, is high, more than 97%. However, the main limitation is that it's anatomy driven. So it depends here. You have this small branch here, and you have to deal with this angulation, and you still should have a lead which will accept to go through this diameter here. From time to time, you don't have any branch at all. It's rare. From time to time, you are facing this situation here, and you cannot cross appropriately the coronary sinus to reach the targeted vein. So there is nothing which could be considered standard in biventricular pacing. And from time to time, you might have such stenosis here, and this is the only branch, and you have to inflate a balloon to be able to insert this. And the reason I'm saying that it's anatomy driven, so most of the time, to be honest, most of the time, we are taking the branch which will allow us to have a good pacing threshold and which allow us to have a good stability. So I'm not targeting a branch which will activate the delayed activated wall. And this is the reason why it's finishing in more than 30% of cases. The LV lead will finish in a suboptimal position, and we will not be surprised that the patient will not respond to this technology. If we are implanting a lead, LV lead, in the apex, for sure, it's the patient will not be responder. And in the guidelines, it is clearly mentioned that we have to avoid implanting any LV lead within the apex. The more you are far from the apex, the more the patient most likely will get benefit. So we should prefer the lateral wall, basal or mid-ventricular, but avoid the apical region. You can see here this patient who was referred because he was not a good responder to CRT. And sorry, it's not, maybe it's not clear for you, but this patient was implanted with a CRT. And you can see here that there is a LV lead. So in AP view, it's looking like basal lateral. However, if you look carefully at the lateral view, and this is not really a rare situation in those who are not using multiple views to be sure that that the lead is really in the good branch. You see here it is anterior. The lead is anterior. It should be posterior. It should be close to the spine here if you want to synchronize. And this is the reason why this patient, when he was implanted with this lead here, posterior, so the quality of the resynchronization was better than when he was implanted with this lead. And this is the situation we should avoid. This is coming from a CT scan. You have the RV lead here at the apex and the LV lead in the apex as well. So don't expect any resynchronization if you are pacing both apex from the RV and the LV. It doesn't make any sense. The idea behind resynchronization, you have to place a lead here in the coronary sinus, here in a branch, ventricular branch of the coronary sinus around this area, close to the spine. And then the RV lead should be within the septum, and then the heart should be taken, the LV should be taken as a sandwich between the LV lead and the RV lead. And this way, you might obtain a really good quality of resynchronization. Device non-optimally programmed, it's not rare at all a situation because it's not only about implanting a device and that's it. The patient who is implanted with a biventricular pacer should have a regular follow-up. And if he is not responding, we should try to understand why he's not responding. And you have here the factors associated with suboptimal response to CRT. And the main reason, and you can see here, this is the most important one, because we are not taking enough time to adjust, to optimize the AV delay. When we are pacing, we need to adjust the AV delay. If the patient is presenting with arrhythmia, high burden of atrial fibrillation, high burden of PVCs, if we don't fix those arrhythmia, the patient will not, because when we are implanting a CRT, we are expecting something like 100%. If it's less than 95%, the patient will prevent the patient from getting full benefit from CRT. 95% is a good percentage of biventricular pacing. It's like when we are giving a patient a beta blocker. So you will ask the patient to take beta blocker on daily basis, 100% of time. So the story with biventricular pacing, the therapy should be delivered 100% of time. And then if the patient is presenting with fast AFib or PVCs, so he will not get biventricular pacing 100% of time. So we have to fix this issue. And currently we are more and more offering to these patients, either because of AFib, atrial flutter, any kind of atrial arrhythmia or PVCs, the solution of ablation, because we should not forget that those patients are heart failure patients and they do have limited option regarding the antiarrhythmic treatment. At baseline, the antiarrhythmic treatment is really very weak to prevent atrial fibrillation, to prevent atrial flutter, to prevent the recurrence of PVCs. So we should not hesitate to offer to this patient ablation, and mainly to fix the AV delay. So if I come back to our patient, as I told you, we were really very happy to obtain such a narrowing of the QRS. The ejection fraction improved from 20-25 to 30-35, but she was still symptomatic. And those patients, we need to complete, during the follow-up, we need to check everything. And as I told you, the AV delay is really something which is really important to be optimized. And in this patient, the AV delay was programmed really too long. Nobody is programming anymore such AV delay, 150 over 120 millisecond. And if you look carefully at the mitral inflow here, despite being in sinus rhythm, the E wave and the A wave are superimposed, they are fused. And not only she is presenting with this systolic mitral regurg, but there is a diastolic mitral regurg as well. So the atrial contribution, the atrial kick is not here. Not only this, but we have a diastolic mitral regurg, and this mainly because of the AV delay was not programmed in an optimal way. And here is where starts the nightmare. And most of the electrophysiologists hate to do this because it's time consuming. You need an echocardiographer to be available with you. You need something like 1 hour to fix this issue. And currently, the device do have algorithm which are able to program up in an optimal way the AV delay and the VV delay, and we should trust them because ourselves we are all overwhelmed by the clinical activity and we don't have enough time to take 1 hour programming the AV delay, and we should trust this algorithm because they were compared to the echo head to head, and it turned out that they are doing the job as we are doing it ourselves. So to make this long story here short, if we are programming a too short AV delay, so the atrial click will be truncated by the closure of the mitral valve. If we are programming a too prolonged AV delay, as in our case, the A wave and the A wave will be superimposed. Not only that, but it will generate diastolic mitral regurg. And you can see here how nice when the E wave and the A wave are completely separated and the mitral valve closure is intervening here. Not like here where the atrium is contracting against a closed mitral valve. So when we did this with the echocardiographer, trying a long AV delay, short AV delay, and there is no magical formula to fix the AV delay. Finally, we obtained a separate E wave and A wave, and you see here that the atrial click is finishing its course, and the diastolic mitral regurg completely disappear, and then the patient continue improving. She was really significantly improving. So the optimal AV delay, if you want a simple definition, is the shortest AV delay, which allows the longest fill-in duration without truncation of the A wave by mitral valve closure. And you have to make sure that at least regarding the fill-in duration here, from where the E wave is starting until the A wave here in this example, is at least equal to 40% of the RR interval. So if you want to improve the stroke volume, you should give enough time for the ventricle to be filled appropriately from the blood coming from the atrium. So those are the basic hemodynamics. And if you are programming appropriately the VV delay as well, you might significantly improve the cardiac output. Let's say we did everything in cardiac resynchronization by biventricular pacing, and still the patient is symptomatic. So we should think about other alternatives. Over time, and that was really a mistake, CRT, cardiac resynchronization therapy, became over time synonymous of biventricular pacing, where it is not. Biventricular pacing is only one way to achieve cardiac resynchronization therapy. QRS duration, even I would say, is not synonymous of dysynchrony, but only a surrogate. CRT is not even treatment of heart failure, but a treatment of dysynchrony currently applied in selected patients with left bundle branch block. So what to do in other patients who are presenting with significant atrioventricular conduction delay, with significant right bundle branch block with wide QRS. So the alternatives to biventricular pacing, because of the limitation I just mentioned, it's mainly, if I want to summarize this slide, it's mainly conduction system pacing and particularly left bundle branch area pacing, and you will see the reason why I'm mentioning this. When we try to pace the His instead of biventricular pacing. And it came, to be honest, even before resynchronization. But the industry was not that much interested in his pacing because we are using a cheap material for it. The Hayes bundle pacing was really a good alternative. Here, this is you are mimicking the physiological activation of the heart, but it had a significant limitation, and this is the reason I will explain the limitation with the Hayes bundle. And this is the reason why everybody switch now to left bundle branch pacing. We are pacing directly because if the patient is presenting with left bundle branch block, so we have just to correct this delayed activation, and then it's making more sense to pace directly the left bundle branch area. So this is the first in human study on left bundle branch area pacing, and they were not calling at that time in 2016. It's not that much far. They were not calling this left bundle branch area pacing. They tried just to compare a right ventricular apex pacing versus a right ventricular septal pacing and LV septal pacing. And you can see here regarding the hemodynamic parameters, we are doing really much better when we are pacing the septum at the left side. And you can appreciate here the difference in terms of QRS duration. This is RV apex pacing. The QRS duration is 190 milliseconds. RV septal pacing 186 and LV septal is 140. And again, it was not, they were not targeting the left bundle branch here. They were just targeting the left septum. And then the question came, because of the limitation, because the anatomy driven biventricular pacing, could left bundle branch area pacing compete with biventricular pacing or even be better than biventricular pacing? If you look carefully here at this tracing, this is really typical left bundle branch block. And when the patient was resynchronized by left bundle branch area pacing, it means that we are crossing the septum here, trying to reach the left bundle branch. You can appreciate how narrow are the QRS. It's not exceeding 104 millisecond. I mean, with biventricular pacing, it's really very difficult to obtain such a narrowing of the QRS. We are able to obtain less than 120, not all the time, but obtaining such a narrow QRS, it's difficult with biventricular pacing. But before pacing the left bundle branch, everything was tried to pace the His bundle. And the His bundle, you see here, the His is a really very small area. So to target this area, we don't have dedicated material for it. The His is really encapsulated and it's really difficult to reach the His. Not only this, but because of the proximity, the close vicinity of the atria, there is atrial oversensing. The R wave is not that much high, and over time, the patient will present with really very high threshold pacing. So this is the reason why it was abandoned by the maximum of centers. They abandoned the His pacing. So everybody now is targeting the left bundle branch because it's really very wide area. You have just to cross the septum 1 centimeter, 2 centimeter below the level of the His, and by crossing the septum here, you might reach the left bundle branch and then obtain such a narrow QRS. And this is really an excellent resynchronization therapy. And myself, I do think it's even better than biventricular pacing because again, it's really very difficult to obtain better than this narrow QRS. So several studies were done comparing left bundle branch area pacing versus biventricular pacing, and all the parameters were favoring left bundle branch pacing, resynchronization by pacing the left bundle branch. As I told you, several studies were done. and including a significant number of patients taken as endpoints, death or heart failure hospitalization. And you can appreciate that left bundle branch area pacing is performing better than biventricular pacing. This is the most recent trial published in 23, either in patient presenting with left bundle branch block with depressed ejection fraction, or patient presenting with left ventricular ejection fraction without left bundle branch block, ejection fraction less than 40%, but they were expected to have something like more 40% of time RV pacing. And finally, it turned out that whatever the parameter you are considering, left bundle branch area pacing is performing better than biventricular pacing, with significant reduction in heart failure. And even the success of implantation is better with left bundle branch area pacing as compared to biventricular pacing. Another study here published just recently, again comparing both biventricular pacing to left bundle branch area pacing, whether we are considering electrical synchrony, mechanical synchrony, or the hemodynamics, left bundle branch area pacing is performing better than biventricular pacing. And it's making sense because we are just mimicking the physiological activation of the heart. So to summarize regarding left bundle branch area pacing, we are obtaining low pacing threshold, a higher amplitude of the R wave, and wider target for pacing compared to his bundle, anatomically at least. And this is the reason again why the majority of the centers abandoned his pacing, and all of us today we are most targeting left bundle branch area pacing. However, it's coming worse with some limitation. There is all the time a risk to perforate some septal arteries. It is rare, and it is happening mainly after several attempts. So we should attempt 1 time, 2 times, not more than 3 times. What is the long-term lead evolution? Because we have some mechanical constraint due to excess myocardial contractile strains on a deep-seated lead, because the lead is crossing the septum. We do have just limited long-term data, since the first study was published in 2016, and really left bundle branch area started in 2017. What is the safety of lead extraction? Because we are crossing the septum with the lead. Nobody has the answer to this question. What is really the profile of heart failure patients who might benefit from left bundle branch area pacing? It remains to be defined. And at the time being, we have to mention that more evidence are favoring biventricular pacing and his pacing as compared to left bundle, because most of the trial I showed you, only a few of them were randomized controlled trial, and those randomized controlled trials include only small cohorts of patients. Most of them are coming from observational studies. We are still waiting for the ongoing trials regarding left bundle branch pacing, and I'm really thinking that those trials, the ongoing trials, will come positive, and it will change our way to think about resynchronization therapy by left bundle branch area pacing as compared to biventricular pacing. So what is the future for CRT for the next coming few years? So CRT will most likely change, because we have another modality to ensure cardiac resynchronization therapy. The rate of implantation failure will significantly decrease. The therapy will improve for sure if we are using left bundle branch pacing. So direct pacing of the conduction system will become a major, if not the major aspect of cardiac resynchronization therapy. There is a hope with leadless technologies. I didn't have enough time to talk about a leadless CRT. The solution exists. We are just waiting for the sanitary authority approval, but it's coming soon, and it will be an important component of cardiac resynchronization therapy. So this is what I had to say regarding cardiac resynchronization therapy. And as it was mentioned by Winston Churchill, now this is not the end for CRT. It's not even the beginning of the end, but it is perhaps the end of the beginning. And I would like to thank so much Dr. Kenneth Edenbogen, who mimics this in a recent major arrhythmia meeting. So Dr. Yahya Al-Hbeishi asked me to say a few words regarding ICD because our colleague was prevented from participating with us in this meeting.
So, Dr. Najmuddin, I think for
Yes,
the sake of time, if you
yes,
allow me to ask you probably a couple or three questions
yeah,
and
sure.
also the topic. So, in brief, I really enjoy your presentation. It's very elaborate. It touched on in the indication of the CRT, the role of the ECG as the main I mean, the predictor of response to CRT. In the past, as you remember, like 15 years ago, we used to do a lot of echo CRT assessment in patient with narrow complex. However, for the last 10 years or so, this has been abandoned, and it's mainly we went back to the basic, which is the ECG. The ECG is the simplest tool to tell us if there is a conduction delay, mainly left bundle branch or not, or prolongation of PR interval. So going back to the basic, the primary selection criteria for CRT is first, the patient has to have a heart failure, has to be symptomatic, he has to have a low ejection fraction, and he has to have the predictor of response to CRT, which is basically depends on the 12-lead ECG. You mentioned them beautifully. It's mainly presence of left bundle branch block, prolongation of the PR interval, which indicate presence of AV dyssynchrony, and some patient with very wide complex, if they are non-left bundle branch, they might benefit, but to a less degree compared to the typical left bundle branch block. And you beautifully describe the how we identify typical left bundle branch block in 12-lead ECG, which is again the basic of 12-lead ECG reading. And also you touched on the role of uh, the uh, the AV synchrony, echo AV synchrony, and the main role now is in AV um, delay adjustment. We don't do it in routine practice because of its time consuming. However, we have algorithm. Also, studies showed that not algorithm are ideal, but we resort to algorithm, which is part of the device basic programming to predict or to program the appropriate AV synchrony, as well as V to V synchrony, RV to LV synchrony. We used to do it routinely, but now I think it is most people will resort to zero RV to LV synchrony. That's what our clinical practice. In specific cases, we look at the 12-lead ECG to predict which programming will be better for the patient, and we do multiple 12-lead ECG looking for the narrowest QRS complex. We start usually with LV early by 20 millisecond, we increase it by 40 millisecond, and then we go back to zero and see which one is the better and to do it. As crude assessment, we programmed our AV delay. If you don't want to adaptive AV delay, we programmed like 80% of 70 to 80% of the patient PR interval. So in this case, you ensure that there is always an LV pacing, and at the same time the longest PR interval possible. Also, you touched on management of non-responder. How can we do to them assessment of the LV lead position, and also you touch on the alternative to biventricular pacing, which is nowadays the center of or the focus of discussion, which is basically conduction system basing. You beautifully described the history of that and what is the latest data about bundle branch or conduction system basing. And finally, he was about to talk about what are the other rules of the electrophysiologist when it comes to devices, because nowadays devices is not simply pacemaker or CRT, but also they have ICD. The ICD can be used in many patients, specifically in patients with heart failure. So if I ask you, what are the most common indication of ICD implanted in your center? So
Yeah.
statistically, patient who get an ICD either in combination with CRT or ICD alone, what are the most common indications? Is it primary prevention or secondary prevention? And what are the usual indications?
So definitely, we are implanting patient in the setting of primary prevention. And most of them are implanted in the setting of ischemic heart disease mainly. And because patient presenting with scar inside the heart might at any time present with ventricular arrhythmia, which could lead to sudden death, any life-threatening arrhythmia, ventricular tachycardia, or ventricular fibrillation.
Subset of patient ischemic heart disease. How do you select those who are indicated for primary prevention ICD in ischemic
So
heart?
So based on the guidelines currently, any patient, whether ischemic or non-ischemic, presenting with severely reduced ejection fraction, less than 35, less than 30%, they are candidate if, despite being on optimal pharmacological treatment, and I'm insisting a lot on this part because the patient should be first on optimal pharmacological treatment before thinking about any device insertion. So in this case, and if the ejection fraction is still depressed, for sure they could be candidate for ICD as for primary prevention. I'm talking about here ischemic heart disease. And since the publication of the Danish trial, which was mainly designed for non-ischemic heart disease, so those patients who are really taking time with pharmacological treatment, and in the current era, we by optimizing, some of them will not anymore meet the criteria of ICD insertion because we are putting them out of less than 35%. They will have something like 45%. They will start improving, and it has clearly demonstrated with the ARNI treatment, with the empagliflozin, as they are participating actively in reverse remodeling by improving the ejection fraction. We are really those patients who are taking time to optimize treatment, and most of them, they will not meet the criteria for ICD insertion. So
Ischemic
I'm making
cardiomyopathy.
clear difference between ischemic and non-ischemic.
So ischemic cardiomyopathy is clear cut. They are high risk population if they have poor LV function. We know must not the must trial. It is the
The
uh,
MADID 2 trial.
MADID-2 trial, ischemic cardiomyopathy, ejection fraction 30% or less. They are high risk of sudden cardiac death. Even if they don't have symptom, they are indicated for primary prevention ICD to prevent sudden cardiac death. Non-ischemic cardiomyopathy, there is certainly group who will benefit from primary prevention ICD, but you are telling me that with the advancement of medical therapy, many of them actually, if you care for them carefully, they will go from the window of poor LV function. Do you
Yes.
do any further investigation in this non-ischemic cardiomyopathy who have poor LV function, like cardiac MRI? You require all of them to have cardiac MRI, looking for late gadolinium enhancement, the magnitude of the scarring in the LV, and how does that affect your decision to proceed with primary prevention ICD in such population? Also, the younger age group, for example, who are in their 30, 40, 50s, do you treat them like somebody who is like 70s, 80s?
This is really excellent question, Dr. Yahya. So as I mentioned it before, in our center, before inserting any device, we are ordering cardiac MRI. The reason for it, as you mentioned, in a non-ischemic cardiomyopathy, still many of them we will find late gadolinium enhancement. So they might present with a scar despite having normal coronary arteries, they might have a scar. So those patients, we are really taking into consideration the presence of scars. So we are not hesitating. We are not taking 6 months optimizing pharmacological treatment. So those patients, when they are meeting the criteria, after 3 months, will go for insertion. And regarding the subgroup of young patients, you're absolutely right. And in Danish trial itself, so those who were aged less than 65 were really getting benefit regarding the prevention of sudden cardiac death. It was not the case for the subgroup exceeding 65 years old. So when it's about young patients, yeah, for sure, we are not delaying the ICD prevention. Yeah.
And the explanation for that, that probably in the elderly age group, they are competing morbidity and mortality reason behind their death. They usually die from other reason like infection or cancer or whatsoever. However, in the young age group, they are relatively healthy other than their cardiac problem. And if you look statistic, they are more likely to die of sudden cardiac death rather than dying from other reason. So there is no competing reason of death or much less competing reason of death in this younger age group compared to the elderly age group. So I think what conclusion you say that there is still rule of primary prevention despite the data from the Danish trial. It doesn't mean that non-ischemic will not benefit from primary prevention ICD. They do actually. Just today, I had an upgrade of patients who had CRTP. And this patient has been with us for a long period of time. And for whatever reason, we decided to put a CRTP like 10 years or 15 years ago. And because she had cardiomyopathy and recovered, and she has some conduction abnormality. So she had CRTP. Her ejection fraction was 45, I think, at that time. And uh, no ICD lead was inserted. It was pacemaker. We did pulse generator change for her, and she came last year. She was transferred from hospital after she had VF sudden cardiac death, despite the fact her ejection fraction is around 50 to 55%. So she improved her ejection fraction almost back to normal, and she has CRTB because conduction problem. And despite that, she had VF. We transferred her at initially, and she was ischemic uh, encephalopathy. We thought we cannot help her. She spent a few weeks with us. She went back to her hospital. Now she came back today because she completely recovered. We did upgrade. So subset of people, especially young people with cardiac myopathy, they are at risk of sudden cardiac death. Maybe statistic will not show it, but there is a group of them, especially if you have an MRI, which shows that they have scar, extensive scar in their cardiac MRI. So about secondary prevention, indication of ICD, it's usually straightforward, Dr. Najmuddin, isn't it?
Yes, 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 it is straightforward. Nobody will discuss it. So patient already presented with an event. So yeah, we have, yeah, secondary prevention is really is more straightforward. But those are not the majority of the patients who are implanting currently. But I fully agree on what you said regarding primary prevention in young patients. As I mentioned before, we should not hesitate. And with the routine MRI, we are discovering that those patients, even non-ischemic patients, they are presenting with a scar. And if you have a scar, even if the ejection fraction is preserved, and mainly if the ejection fraction is preserved, the more limited is the scar, the more it will favor a reentry circuit, and those patients will present with a life-threatening ventricular arrhythmia. Those who are presenting with really significant extensive scar, they will die from pump failure. They will not die from ventricular arrhythmias. I'm talking about advanced stage with scar everywhere. So those patients are less likely to take benefits. So maybe just to be a little bit provocative, for years, maybe we were not implanting the right patient. We were focusing on the patient. So what is the rationale behind implanting someone with ejection fraction less than 10%? And if with MRI, you see that he has really extensive scar everywhere. So he will die from electromechanical dissociation. He will die from pump failure, not from ventricular arrhythmia.
And that
We
has
should
been
keep,
shown by in SCAD heft. I think those who are, I think, class 3 and 4, they don't benefit much of ICD
yes, yeah.
because they die mainly of pump failure. And actually, those who benefit more is class 2 patient. In SCAD heft, I think it was 2000, I don't know, 2008 or 9.
Codeft, yeah, it was 2008, yes.
Yeah, okay, 2009. So it did show that those people who are advanced heart failure, they usually die from pump failure or infection or from hospitalization rather than sudden death. And those who are less symptomatic class 2 specifically are they are likely to die from sudden cardiac death. So if I want to summarize for my colleagues, and I always mention it, look at the ECG predicting patient who are for CRT, and usually say there is six indicator of response to CRT in ECG and non-ECG. First, if you have non-ischemic cardiomyopathy, they do respond to CRT better than ischemic cardiomyopathy. And because dead muscle does not beat, because if you have extensive scar like LAD, you are less likely. You might still benefit from resynchronization, but the benefit is less compared to non-ischemic cardiomyopathy. Second, if you have a female patient, they are more likely to be super responder. If you have typical left bundle branch as compared to intraventricular conduction delay or right bundle, if you have QRS duration more than 150 millisecond, that's another indication of super responder. If you have a first degree AV block in the baseline ECG, and another finding is that if you have evidence of early right ventricular activation in the early part of the QRS complex, if you see that notch, which resemble a pseudo delta in the beginning of QRS complex, it does indicate that this is the RV activation. So the RV is being activated before the LV, and the LV comes. So it resembles a pseudo delta wave. So if you have all of these, female 6, non-ischemic cardiomyopathy, left bundle, and wide QRS complex more than 150, first degree AV block, and the notching in the beginning for the QRS complex, you are almost certainly that these patients will benefit from CRT and were likely to be super responder. So I'd like to thank you for your time, and because we are running out of time, I'd like to introduce my colleague and friend, a senior electrophysiologist in our country, Dr. Naeem Al-Shaibi. He's a chief of cardiology at King Abdulaziz University, as well as Suleiman Faqih Jeddah Hospital. And he will touch on a very important topic. And actually, to link it to your presentation, Dr. Shahidi, one of the main reasons of non-responders to CRT is
Atrial
atrial
fibrillation.
fibrillation. So atrial fibrillation patients, they tend to not to improve with CRT unless you do certain things. You do ablation of the AV node, ensure that they are basing all the time. The percentage of basing is more than 94%. So this is one of the problems related to the atrial fibrillation in patient with heart failure. I'm sure Dr. Naeem has a lot to say about this topic. Dr. Naeem, the mic is yours.
I think you are muted, Dr. Naeem.
Okay, thank you, Dr. Yahya. Thank you, Dr. Najmuddin. Yes, as you mentioned, one of the failure of current therapy with the heart failure is atrial fibrillation. So I've been asked to touch based on the rule for catheter ablation to maintain sinus rhythm, and hopefully we can help patients with the heart failure. So if we can move the slide. So just quick word in epidemiology. We know that AF reduces cardiovascular performance in multiple ways. Most important, the loss of AV synchrony, reduce filling time. If you're reducing filling time, you're going to reduce the ejection time and reduce the ejection fraction. And you have a lot of prevalence of right ventricle dysfunction in a patient with atrial fibrillation. So it's not only disease that affect the left ventricle, affect the right ventricle as well. Who comes first? AF brings heart failure or heart failure brings AF? I think they are married well to each other according to the NYCHA classes. As you go with the more of a heart failure, you'll end up by having more of atrial fibrillation. So just let me put the mouse here. Okay, good. So I'm not sure if this can move my slide.
Joanne, can you help with that? Maybe
I'm not able to move the
you
slides.
reshare. I think unshare and reshare again, please.
Let me see that. Stop sharing. Okay, share my presentation.
You know, the Russian way to fix things is turn it off and turn it on again.
Yeah, this is the AP way, actually. It's not a Russian way. All right. So as I mentioned, that if you have a progressive heart failure, the incidence of atrial fibrillation goes up. If you have in a 2HA class 1 and 2, the prevalence of atrial fibrillation is around 5%. As you go into stage 3 and stage 4 of NYHA class 3, you'll almost have 50-50 chance to have atrial fibrillation and a heart failure. Heart failure is not only disease of reduced ejection fraction that we know that is it's a symptoms. You could have a good LV function, what we call HFpEF, as HFpEF is very common in our region due to a lot of diseases of diabetes and hypertension, and those carry the same risk of having atrial fibrillation. The problem with the atrial fibrillation that increase the risk of mortality and morbidity. So it's not only that, it's give you a very poor outcome, increase the level of readmission, all-cause mortality, and heart failure mortality. So it's a very complex disease. It's not about only thinking about fast heart rate. It has a lot of problem with electrical remodeling, increase left atrial dimension, increase the chance of having severe mitral regurg, increase the filling pressure. You have a lot of fibrosis, chamber remodelings, changes in neurohormonal. So it's a multifactorial who brings what? Atrial fibrillation brings heart failure, and heart failure brings the atrial fibrillation. And as I mentioned, it's a word about mechanics. You have loss of atrial kick, and that's contribute almost 25 to 30% of the cardiac output. What a problem with the tachycardia? You have increase in calcium handling, increased sympathetic tone, and we know sympathetic drive is very bad with the patient with the heart failure, as increasing the heart rate. You'll end up by having more symptoms of a heart failure and worsening of volume overload. Worsening in the ventricular function can lead to tachycardia, induced cardiomyopathy. In this graph, this is a very illustrated graph that if you start with the heart failure today, then this is increasing the chance of having atrial fibrillation by time. And vice versa, if you have atrial fibrillation today, there will be increasing the risk of having heart failure, whether it's a HFrEF or HFpEF. So we can see that there is temporal relationship between atrial fibrillation and the incidence of heart failure, and the temporal relationship between heart failure and incidence of atrial fibrillation. Unfortunately, it's not about only incidence, it increases the mortality as well. So if you have a heart failure with atrial fibrillation, the high risk of likelihood of dying is much higher than the patient they have heart failure with no atrial fibrillation. So atrial fibrillation, heart failure, it's almost is a killer disease. As we know, there is a lot of advancement in the last 4 to 5 years in treating patients with reduced ejection fraction, MRA, RNA, SGLT2, and beta blockers, and that's became the standard of therapy for any patients with the heart failure. And let's see that is that enough, or we should keep sinus rhythm in top of those medications. So if you look back before the era of good ablation therapy, if you look for the rhythm controlling strategy with anti-arrhythmic drugs. Multiple studies, yes, small studies. Maybe Diamond CHF was the biggest one of them, and Affirm and the AF-CHF trial was among one of them. But all of them, as anti-arrhythmic, failed to show any mortality benefit. Yes, they might able to maintain sinus rhythm, improve quality of life, but none of the medical therapy has shown benefit compared of a standard therapy. Even if you go with all antiarrhythmic cardioversion, that will fail. Again, it's just a rate controlling strategy. But if we reviewed all the studies that look into ablation catheter for atrial fibrillation, I will concentrate on the three biggest one, the AATAC, the CASTLE AFib, and Cabana heart failure trial. As you see that even the definition of heart failure in those trials are different. Some of them, like Cabana, look into only NYHA class 2 and 4, irrespective of ejection fraction. That's mean in Cabana heart failure trial, look, we have a lot of patients with a preserved ejection fraction. With the ATAC, look into ejection fraction less than 40%, and you have to have NYHA class 2 and 4. And CASTLE AF, look into NYHA between 1 and 4. But if you look deep about the who are they, you're gonna find a lot of patients in class 1, NYHA class 1, class 2, and class 3, but it's very rare to have a class 4 with ejection fraction of less than 35%. That's mean, with all due respect, with all study that we have not looked into severe heart failure. We are looking always in a mild reduced ejection fraction up to 35, less than 35%, and we will show you the evidence what we have with those. And all those trials showed a superiority of atrial fibrillation. And when we talk about atrial fibrillation, we look at the PVI, pulmonary vein isolation, plus what the surgeon or the ablationist do during the procedure. He will include doing something else beside the PVI, or he will stay with the PVI. And you see in all those trials, PVI was done for all of the patients, but only 50% they end up by PVI alone, not to have another line. And I will touch base on those three trials. So we'll go to the AATAC study. Again, ejection fraction less than 40%. In NYHA class 2 and 3, they could have defibrillator. The patient will be like paroxysmal persistent AFib. BVI plus additional line, it depends on the operator, whether he's gonna do posterior, roof line, mitral line, cafe, trigger. This is according to the surgeon himself. So what they found, that the freedom of atrial fibrillation in a patient on the catheter ablation group, it has better result compared to group 2 with only medical therapy, which is strong medication and amiodarone. But at the end of the 2 years, they found that catheter ablation, they increased the probability of a sinus rhythm by 70%, decreased the unplanned hospitalization, decreased the all-cause mortality, and a very low risk of a procedure, and looks very, very good at the beginning. What about the CASTLE AFib? Look at the ejection fraction less than 35%. This is more aggressive group in NYHA class 1 and 4, but as I mentioned, class 4 only was representing in 1% of the population. And again, the patient will have paroxysmal and persistent atrial fibrillation and PVI plus whatever the MD looks like to do during the procedure. And if you dig into the result of this trial, if you look for the hospitalization of worsening heart failure, there is an early separation of curve between the ablation therapy and the medical therapy group. But to have a mortality benefit, you need to treat those patients up to 3 years to see the separation in the group and the between the ablation and the medical therapy. So CASTLE, again, it's a mortality benefit, but after 3 years, but reduce the risk of worsening of heart failure in the early 6 months after the procedure. And if you look deep into the freedom of atrial fibrillation between medical therapy and ablation, if you do the ablation, here's the blue line, you have more freedom of atrial fibrillation, less recurrence compared to medical therapy, and this is why they have low risk of recurrence admission to the hospital. But if we dig deep into all the subgroup analysis of the CASTLE AFib, is the AFib good for all patients with the heart failure. I think the thing that we have to look into deep, that once you reach class 3 heart failure, NYHA class 3, maybe you get a marginal benefit of ablation. But once you cross stage 4, maybe there will be no benefit. If you have severe reduced ejection fraction, 25%, maybe ablation procedure by itself, it has no benefit in terms of mortality and reduced risk of recurrence. So this means not all heart failure with ejection fraction less than 50%, we should treat them as a one disease. So we have to have cigarette symptom-wise, NYHA class. What is the NYHA class? And the other thing is what is the ejection fraction. And then lastly, I will discuss with you the Cabana heart failure trial. Again, with those patients, we have a lot of patients with near normal LV function, but they have preserved LV function with the NYHA class 2, again, showed less risk of recurrence atrial fibrillation and more mortality benefit and ablation therapy compared to the drug therapies. And all is not only the death, stroke, and serious bleeding, cardiac arrest, but all-cause mortality was much better in the ablation arm compared to the drugs therapy. So that's give us a new insight of treating heart failure in a preserved ejection fraction. Again, if you look at the freedom of atrial fibrillation, whether at 1 year or after 4 or 5 years, it seems ablation early on predict and reduce the risk and the freedom of atrial fibrillation. So if I summarize them, so catheter ablation heart failure overall is effective. We have to make sure that we're reducing the risk of arrhythmias, risk of recurrence, and that has been shown in all the 3 different trials that I talked to you about. Again, in the Castle AFib, the main result by reducing the risk of the AFib burden, the Cabana, the only study that looked into patient with preserved ejection fraction. What about reducing the heart failure admission, the ATAC and the Castle heart failure? It showed much way benefit of reducing the admission of the heart failure, especially in the group of NYHA class 2 and ejection fraction more than 25%. What about mortality? All of the 3 trials showed mortality benefit with good number to treat in all those trials. And again, we have to think seriously about reduced ejection fraction because we do not have much of a details in a very poor ejection fraction. But now we know that AFib ablation is good in a patient with heart failure, but really the most important thing is the time. If your flight is departure, there is no rule to go to the airport. You're not going to find anything. There will be no help. So in this study, look into the East EFNet network 4 trial. What is really important, whether you have HFpEF or you have reduced ejection, very reduced ejection fraction, or mid-reduction ejection fraction, what is very important is the timing. So if you do those early, you decrease the risk of recurrence, you have improvement in the mortality, reduce the risk of cardiovascular death, and it showed this has a very safety network. But what's important is do it as early as possible. In the East AFNet 4 study, look into 36 days from the diagnosis of atrial fibrillation in a heart failure population. Is it safe procedure? This is multi-study look into what is the safety, ablation safe or has the risk same as just continuation of a medical therapy. And we know now we have a lot of advancement on the technology, how to do the pulmonary vein isolation. The most risk that we have is by having a risk in the access site, but other risk is almost less than 1%. Having said that, only if you're going to continue medical therapy is, again, this has a risk always higher, looks like more even higher than the risk of the ablation by itself. So for this, it's beneficial. It has a safe procedure. The most important thing that we have to do it as early as possible. But we know trials are good. People are perfect in doing trial. They have perfectionist in terms of follow-up. What about real world evidence? Look at the efficacy of catheter ablation heart failure in a real life patient. This is data from Canada. Look in the patient, if they have AFib ablation, they have reduced in all-cause mortality. So that's mean this data has been replicated in a real-life data. Again, this is the data from US. Look into the patient who has Castle eligibility in the Castle eligibility study, and I will show you what the patient who is excluded from the study. If you have Castle eligible study, that if you have, then you'll get improvement in mortality if you're eligible patient in the real world. If you failed to meet, but you have some of the criteria, still you're going to get ablation benefit in terms of reducing the mortality. But if you're looking for the patient that has been excluded from the Castle, then there will be more, there is no benefit from ablation therapy. And this is the exclusion criteria. And what is important, if you have patient with uncontrolled hypertension, there is no rule to do an ablation. You're not going to get benefit. If you have super dilated left atrium more than 6 centimeters, most likely you're not going to get benefit. If the patient has listed for transplant, or he has a assisted device, that, or he have a life expectancy less than 12 months, what does that mean? That in a patient with very advanced heart failure, maybe BVI or AFib ablation is not beneficial on those treatment options. So how to predict response? A group from Europe, they put their data together. This is only internally validated, it's not validated by the other study or by other group. So look into, if you have more points, that means you have less likely to have recovery of the ejection fraction based on AFib ablation. That means if you have QRS more than 120, then most likely you're not going to get a lot of benefit from AFib ablation. Patient with a proximal AFib, they get 1 point. If you have very late activation volume index, then you'll most likely, you're not going to get benefit from the atrial fibrillation ablation. Known etiology and treated etiology of atrial fibrillation or cardiomyopathy, then most likely put you in non-responder groups. So to be a responder, you have to have an QRS. Etiology has to be treated and well known to be managed. And patient with a very late volume index, then the most likely you're not going to respond from the ablation procedure. So about what about patient with AFib, permanent atrial fibrillation, heart failure, and QRS is narrow? We've seen the excellent data shared by my colleague, Dr. Najmuddin, in terms of device therapy. Is there a rule to control the rate where AV node ablation and implant CRT against drug therapy alone? If you implant a CRTD with ablation to the AV node, it seems to be have a mortality benefit compared to the drugs therapy. That's giving you the rule of very controlled heart rate. And look in the same study that I show you, whether you did AV node ablation plus heart failure, you decrease the risk of death, whether you have ejection fraction less than 35% or more than 35%. So result, this is something that we should think of. If you see a patient with reduced ejection fraction, permanent atrial fibrillation, you give him all the medical therapy with a recurrence admission, maybe there is a rule for AV node ablation and CRT therapy device. Looking for the all data, we know the all good drugs, the directed medical therapy for heart failure. All of us, we know what's the benefit of the beta blocker, MRA, RNA, CRTD device. But if you look for the huge difference in the intervention group between beta blocker and control group, you have 11% or almost 12% improvement in a beta blocker. But AV node ablation give you much better result for the all medical therapy that you know. It has a better result than the beta blocker, than the ACE, than the ARB, than the RNA. So AV node, catheter ablation, pulmonary vein isolation plus line, it has a great impact in a patient with atrial fibrillation. Maybe it's better than all the medical therapy that we know for the heart failure. So if we're going to think about patient with atrial fibrillation and reduced ejection fraction, before we subject them to catheter ablation, we have to think what is the likelihood of this patient will improve and have a mortality benefit, reduce the risk of admission, and has much of a control in their symptoms. If you think this is AFib-mediated cardiomyopathy, then go ahead with a catheter ablation procedure. And if it's early on stages of a heart failure, class 1 and 2, then go ahead with the AFib ablation. If you have no significant scarring in the MRI, go ahead with ablation. If none or mild atrial fibrosis, then this is good. Early persistent paroxysmal, will be a good target for pulmonary vein isolation plus line. Younger patient, as Dr. Yahya mentioned in the discussion, they always get a good benefit from device therapy and early ablation. So to take home message, early ablation is the lead to get a good benefit of a result compared to ARNI, MRA, beta blocker, and SGL2. Catheter ablation is the fifth pillar in a patient with atrial fibrillation management with the heart failure. Substrate modification, it has a great impact. This is why in my practice I became very aggressive in putting patients on a table not to end up by pulmonary vein isolation. Always do posterior line, always do roof line, flutter line for everyone. Before I conclude, I want to show you this. This is the new RAFT trial that I need the help of my colleague that our region, Saudi, became nominated to share in this trial and basically look into patients with chronic heart failure, atrial fibrillation, rather than do ablation of AV node plus CRTD. You do ablation of AV node with the bundle pacing, and again, it's pharmacological therapy. With any center that needs to be included in the study in the Saudi, we are welcome him to participate. I know Dr. Yahya's center will participate. We know that the National Guard in Jeddah will participate. A couple of hospitals in Jeddah showed their benefit, and this is why I want to share it with everyone. If you think that you have a so good substrate of patient with atrial fibrillation and heart failure to be part of the study, we welcome, and this is a chance for us to be in the map, to be presented in one of the elite study. And that study should start kicking in 2 to 3 months, inshallah. With this, I conclude my talk. Thank you.
Thank you very much, Dr. Naeem. Elegant presentation as usual. I cannot stress more that our patient with atrial fibrillation are actually under-treated, probably are missed, are not diagnosed early, and no enough attention are paid to atrial fibrillation, and that's especially with patient with heart failure. It is a very bad combination to have heart failure and atrial fibrillation. You should always aim for early ablation of atrial fibrillation in any patient, especially in patient with heart failure. And as Dr. Naeem mentioned, that usually does not involve simply pulmonary vein isolation, and we have study to support that doing a PVI in patients, especially if they have persistent atrial fibrillation, is less likely to have a long-term impact. Usually you need to do more than like roof line, posterior wall, and sometimes mitral isthmus and cave. Patients with heart failure tend to have a lot of substrate within the left atrium. And unfortunately, have seen many patients who are in heart failure, they are suffering, and they are left for years and years without even cardioversion in our country. This is not acceptable. If you think you are supported by data from obsolete study like AFFIRM, which should look at very particular patient at specific era, now we are in 2025. This is not applicable to our patients. Patient with heart failure, or even without heart failure with AF, should be at least discussed for rhythm control. Every patient deserves to be in rhythm control. The exception is actually those few patients, they might not benefit from rhythm control. Most patients will benefit from rhythm control, specifically atrial fibrillation. So thank you, Naeem, again, and just want to point out that there is a small study done, I think it's a center study, European study, is called the Castle Transplant, which is basically a small number. I remember it was 80 patients, and they look at those end-stage heart failure patients, those who are on the transplant list, or they have mechanical support, and they did ablation to them waiting for the transplant or the mechanical support, and they did find mortality and morbidity. Even in those people, they found mortality and morbidity benefit from atrial fibrillation. So imagine that if you consider it earlier in younger patients, the benefit will be much more. We are short of time, and I think we still have one presentation. We already exceed the presentation, but I'm personally enjoying, and I think the audience also enjoying. I didn't see any much of questions. Is it blocked? We are gonna answer question live. So if you have any question, please type it. I will gonna start my presentation, and I promise to make it as short as possible. So do you see my slides?
Yes, it's there.
Okay, so my presentation, we touch on the device therapy and their role in patient with heart failure. Dr. Naim touched on in atrial fibrillation patient. And another major problems with patient with heart failure is ventricular arrhythmias, whether it's ventricular tachycardia or the BVCs. I'm not gonna talk about all the subject because this subject alone will need a separate webinar. However, I will talk about the BVCs. After a brief introduction, I will discuss whether you think BVC are benign and what is the BVC burden, which is usually linked to cardiomyopathy, and how to differentiate between BVCs associated with structural heart disease and heart failure associated with structural heart disease and BVC-induced cardiomyopathy. How we do PVC mapping and ablation, and what is the success rate of PVC ablation, and we'll conclude with summary. Most of the data I will talk about the technique related to PVC. It's actually applied to ventricular tachycardia. So PVC are common in the general population. It is estimated that at least 1 to 4% of the general population would have BVCs. And it actually depends on the duration of monitoring. For example, if you do a standard 12-lead ECG in the group of the attendees, we have about 70 attendees in this webinar, and you will find 1% of the subject would have at least one BVC. If we extend the monitoring for 24 hours or even longer for 48 hours, the prevalence of BVC will increase to 40% to 70%. So most of us at one time of our life would have 1 or 2 BVCs, and to be honest, it's not a good experience to have it. However, these rare BVCs or occasional BVC is not a problem. The problem is when you have a high BVC burden. Traditionally, we consider all BVCs, whether they are low or high burden, to be benign. However, nowadays, there is accumulating evidence that these BVC are not always benign. So I always like to quote this study, which was published, I think, in the year 2015 in JACC, and it is a population-based study. It looked about ventricular octopy as a predictor of heart failure and death. And they divided patients into 4 quartiles. And these quartiles, quartile number 1, almost they have 0 BVCs, no BVCs, like the general population. And the 4th quartile, they have from around less than 1 to 17%. So most of the 3 quartile, less than 1%. And when they follow up these patients for more than 15 years, they found that those who have in the 4th quartile, i.e. BVCs around 1 to 2, 3, 4, 5, 6, up to 17, they have lower proportion disease-free survival, and the prevalence of congestive heart failure is much higher. Also, the 2 groups in the baseline characteristic were comparable. However, if you look specifically for heart failure, presence of PVC will increase your 15-year CHF risk from 16%. If you have 3% PVC burden, it will gonna double in 15 years. If it's 10%, it's much more than that. If it's 20 or 17%, it's more than 35%. So presence of PVC burden is not a benign condition. It usually predicts increased risk of heart failure and probably increased risk of mortality. So let's discuss a classical scenario. We see it in every day. A 40-year-old male, he has no diabetes, no hypertension, basically no risk factor. He had a cardiomyopathy. His ejection fraction is severely depressed, 25%, and he has a normal coronaries. But he had a 40% PVC burden, and he's symptomatic with NIHA class 2 to 3. And this is his 12-lead ECG. The first time we see this ECG, we know these are outflow tract PVCs because they are positive in the inferior leads. And we know it's probably coming from the left side because if you look at the transition of the PVC, transit before the sinus beat. This is what we call it transition index. And it has a very specific morphology in V1, which is the QS pattern. If you see it, it almost always points to one of the, I would say, common site of origin of PVC. It is from the coronary cusp, specifically between the right and left coronary cusp. And this is what we found when we took the patient, the catheter here in between the cusp, and it was quite early. In 5 minutes, patient is out of the lab after we mapped his PVCs, ablated, no PVCs after ablation. Patient did very well. He's off. He has been initially an ACE inhibitor beta blocker, but after a prolonged follow-up, we stopped it because ejection fraction improved within 4 months, but we didn't stop it right away. We gradually decrease it. We follow up the patient for 2 years. He maintained his ejection fraction, and we still, until today, I think that was done more than 10 years, and he's still doing fine without any medical therapy. So this is a classical example of patient who has PVC-induced cardiomyopathy. Yes, usually they are from the RVOT because the RVOT cause more dysynchrony because the QRS complex tend to be more wider, but LVOT is quite common source of these idiopathic. I would say these PVC actually, they come from the LV summit, and sometimes they exit because they are from the portion of the summit near the cusp. They exit at the cusp. Sometimes they exit from the RVOT, sometimes they exit from other sites. So summit PVC are common, and they could be associated with cardiomyopathy. We don't know the exact prevalence of PVC-induced cardiomyopathy, know enough data about it. Usually it's underappreciated, underdiagnosed. I remember during my residency, when we see a PVCs, whether it's by Gemini, we don't pay a lot of attention. Nowadays, I think people are more and more aware that these PVCs are not benign, especially if they are associated with symptom, especially if they are short coupled, especially if they are associated with poor LV function. We still don't know how much PVC is needed to cause cardiomyopathy. However, a PVC burden more than 5 can likely cause problems. 20% or more, even if the patient is asymptomatic, we tend to do ablation for them. In between 5 to 20, we take the case by case. So if somebody can have a 5% PVC, I would not say I wouldn't tell him that you are okay. I would follow him. Maybe I will not take him right away for ablation unless he's very symptomatic. But certainly, if you have a very high burden of PVC, even if he's asymptomatic, we will advise him for a PVC ablation procedure. The discovery about PVC-induced cardiomyopathy is not quite new. It has been the first report. Has been in 1998, and that was even before the ablation of PVC procedure started. The observation of that you suppress PVC with medical therapy the LV function improve. And this entity of PVC-induced cardiomyopathy was defined. Since then, we have a lot of studies. Most of them are small studies, which looked at first improvement in various parameters, especially in echo, whether it's the LV function, the ejection fraction, the dimensions, and the symptoms. And I would say all the study I came across, whether they are small study or large study, when the PVC performed and it's successful, it almost always improves the patient condition, whether it's at the symptomatic level or the LV dimension or ejection fraction. And I cannot count the example we came across. We see it in our day-to-day practice. So especially in patient with heart failure, if you do PVCs ablation and it's successful, they're gonna improve whether in symptoms or dimension or ejection fraction. I will not go in the details of these studies, but these are the name of study if you want to review it later. So why PVCs cause cardiomyopathy? The exact mechanism, we don't know it, but however, there is potentially different mechanism. First of all, alteration of the RR interval or the alteration in the rate. So you get a PVC, short RR interval, then prolonged RR interval, then short again. That's by itself will cause cardiomyopathy. Autonomic dysregulation related to the PVCs, increased oxygen consumption during PVCs, ventricular dyssynchrony. PVCs cause dyssynchrony, especially if they high burden. Then most of the time, the patient lives with dyssynchrony LV activation, because especially if they come from the right or even from the left, it seems to be wide complex, and the lateral wall, the septum will not contract in the same time. And this is by definition, like if you have a left bundle branch block. Tachycardia, PVC is a short R interval. It mimics tachycardia and it causes tachycardia-induced cardiomyopathy. It also acts at the cellular level by affecting the calcium handling with myocytes. And those who are doing hemodynamic or cath, if you look at the change in blood pressure following PVC, it's not a minor thing. You see significant change in hemodynamics during PVCs. Usually the PVC, as I mentioned earlier, they are related to the LV summit. I'm talking about majority of idiopathic PVCs. They come from the LV summit, which is closely related to the LVOT, RVOT, and the cusp. So that's why most of the PVCs we ablate from the RVOT or from near the left coronary cusp, just below the cusp, sometime from the venous system, the extension which goes and look to the LV summit from the other side of the heart. So if you you put your catheter all the way inside your stress, it will loops around the lateral wall of the LV and then to the anterior, and you will be looking at the anterior aspect of the LV summit. Some of the summit PVCs are actually not accessible endocardially, and even epicardially. If you do epicardial procedure, they will be covered by a thick fat, especially if they are high up from the LV summit, and you will have a major coronaries right away there, so you cannot ablate. So we utilize the ECG. As you know, the ECG is the most useful, most cheap, easily available anywhere to try to localize the PVCs. In simple term, I will not go in details of the localization of the PVCs because this is a long topic. However, PVCs who comes from the left ventricle would have a positive V1, and PVCs who comes from the right ventricle, they tend to have negative V1. And as the transition get later, that means the PVC is coming from the right side. Early transition indicates PVC is coming from the left system. So if you have inferior axis, PVCs, positive inferior leads, the IE from the outflow tract, if they transit beyond P4, i.e. P4, 5, 6, start to become positive, that means it's probably RVOT. If the transition is in V1 or V2, it's from the left ventricle. If it at V3, you have a 50% chance it will be from the right or left ventricle. And then you look for other parameters. I mentioned already the transition index. So if you have a BBC which transit at V3, like this one, so if you see it, V3 is positive. And however, what is the transition? The BVC, the sinus rhythm become positive before the BVC. The BVC is only become clearly positive in V4, but sinus beat is clearly positive in V3. So the BVC transit later than the patient on intrinsic QRS. So you are taking the QRS as the control in his case. So to adjust for any misposition of the lead. So in this case, you are almost certain that it is from RVOT origin. However, if the PVC transition is before the sinus beat, that means it's most likely 70% chance it is from the left ventricle. So other issue we look at the BBC localization is whether it's from the endocardial or intramyocardial or epicardial. And that's usually is looked for by assessing the upstroke of the QRS complex. If it takes most of the time of the QRS duration in the upstroke, i.e. from the beginning of the QRS complex to the peak of the QRS complex is more than 55% of the total QRS complex, you are almost certain that the exit of the BVCs is from the epicardial surface. If the upstroke is sharp, it's most likely it's engaging the conduction system early. That means it's probably from the endocardial surface. So this is an example of the location. We see patients in a daily basis. You get them from different side of the RVT. This was, I think it was a lady with ejection fraction. This is classical PVC from the RVT. You ablate them, they improve ejection fraction. And usually the procedure takes less than 1 hour. You sometimes get a patient who are from the right ventricle, like this example. This patient it was from near the tricuspid annulus. Again, this patient had mild LV dysfunction, which has improved with post-ablation. I know we are running of time, so I will go through this very quick. This is our example. Sometimes you get BVC, which is between the right ventricle, and you have to ablate or sandwich it from both sides of the ventricle, from the right ventricle and from the LVOT. Another example, 35-year-old male, non-ischemic cardiomyopathy, ejection fraction 25%, symptomatic PVC burden of 32%, EF improved on medical therapy. However, down again to 30% despite treatment with very aggressive medication with a lot of side effect, which is amiodarone. And this is the BVCs of this patient. And you see the transition here. If the BVC is quite early, almost V1 has a positive R wave, V2 is quite positive. So, and it has inferior access. So it's most likely it is coming from the LVOT. And this is how does it look. The upstroke of the BVC is taking most of the QRS duration, i.e. it's epicardial origin. And this is where we found the BVC. We put it through the CS, and the distal part of the CS, there was early activation, and we ablated. However, it is a very dangerous place to consider ablation because it's a venous structure, and you might have major coronary arteries in that location. So you have to be very careful, and we only resort to this approach in a very limited cases. So this patient did well post-ablation, and his ejection fraction improved, and he was stopped from this nasty amiodarone therapy, and has doing well since then. So just to make a brief summary, if you have a young patient, especially if they are female, if they have global rather than regional LV dysfunction, and their LV wall thickness is preserved, we always do cardiac MRI. Dr. Najmuddin mentioned that almost every patient, we do the same. Almost every patient with cardiomyopathy, we obtain cardiac MRI. There is a lot of data. You can get it from cardiac MRI. I always say definition of structurally normal heart before MRI and after MRI is totally different. So it doesn't depend only in the echo finding, but also the MRI finding. Sometimes you get a normal function, but you do MRI, you do a lot of fibrosis. So if your cardiac MRI did not show significant late gadolinium enhancement or fibrosis, if your BBC burden is high, more than 20% of the total QRS numbers, and especially if they are more than 20,000 per 24 hour, and they are monomorphic rather than polymorphic, and especially if they are from the RVOT, these type of people who are likely to benefit from ablation, and these type who are actually has what we call it PVC-related cardiomyopathy. So look carefully for these type of patients. These are those the type of patient who benefit from an early ablation procedure, and you might cure them from this disease, and you cure them from heart failure. So in summary, PVCs are common, whether in patient with heart failure or patient without heart failure. They are not always benign, and they could be symptomatic. Especially you have to pay very close attention for those who have short coupled PVCs, because they could be at high risk of ventricular arrhythmia or sudden death. Look carefully for the morphology. Is it a monomorphic? Where are it coming from? And how much the burden? And obtain cardiac MRI in almost most, I would say, most patients with presenting with high PVC burden should have cardiac MRI, and consider ablation of these PVC, because the procedure is highly successful and it's quite safe. Thank you for your time, and thank you for being with us. And by this, I end my presentation, and it is the last presentation here. If there is no question and no comment from my colleagues, I think it's probably time. It's already too late. It's almost 10 o'clock now. We can conclude our meeting. So Dr. Najmuddin, do you want to have any comments?
No, thank you. It was really very clear and, as usual, really excellent and comprehensive presentation from yourself and from Dr. Naim as well. I really enjoyed a lot your both of your presentation. No, it was really clear from both of you, so I don't have any question or other comment.
Dr. Naim Al-Shaibi, any comments or anything you want to add? Anything?
Thanks. Thank you. It's not a comment, but it seems heart failure is a very complex disease. A lot of things can cause heart failure. Heart failure can cause a lot of things. What is very important is just to tackle the main reason for the heart failure. As you mentioned, the BVCs is one of the main cause of cardiomyopathies that is missed, especially in young female patients in our region. We see a lot of them with the late presentation of BVC-induced cardiomyopathies. And the thing that I don't like, abusing the medication, especially amiodarone. I think if you look for the data of electrophysiologists, they're rarely using medications like amiodarone because we know that it has a lot of side effects. And I see a lot of, unfortunately, mismanaged patient, young female with a lot of amiodarone only because of the BVCs. Where now with the catheter ablation, we have a good cure therapy. A good touch up with the use of cardiac MRI. I think cardiac MRI is very useful to predict, and at least every patient with heart failure, it's worth to have an MRI even before implantation of any devices, because with the future we can tell about a lot of changes in the history of the patient with heart failure if we know the baseline MRI. Catheter ablation is a very safe procedure, and whether in patient with atrial fibrillation, and there is a lot of advancement in technology in plating atrial fibrillation, very safe procedure in BVC therapy. Managing device therapy as well is very important. not as Dr. Najmuddin said, it's not always about implantation of a device. You really know how to program it. You need to have a good follow-up system for the device implantation. For this, I think nothing else to add.
Thank you all. And this is our first webinar this year from the electrophysiology group at the Saudi Health Center, and more coming. Stay tuned. And I think we'll have more topics to cover, whether it's related to heart failure, whether it is to atrial fibrillation, whether it's related to devices. Probably in the coming 2 months, we have another webinar. And I'm sorry to keep you delayed, but I myself enjoyed the webinar. I enjoyed the presentation by Dr. Naeem, by Dr. Najmuddin, and it was very educational to me. Please send us your comment if you have any suggestion. And sorry for not taking your question. I didn't see actually any question in the Q&A section. Is it blocked? I didn't know, but no question came to me. It seems that everything is clear, and you made it very clear, Dr. Najmuddin and Dr. Naeem. Thank you, and have a good night, and happy Foundation Day, and happy Ramadan, inshallah, in the coming 10 days.
Shukran. Thank you. Thank you.
شكرا جزيلا.
شكرا لكم. Good night.
Bye-bye. Bye.